Hello everyone, welcome to Medicine in a Flash. Today we are going to talk about pericardial diseases. Pericardium is a sac-like structure which covers our heart. It is made of two layers: inner serous pericardium and outer fibrous pericardium. Inner serous pericardium has two layers: visceral pericardium and parietal pericardium. In between these two layers, there is pericardial cavity, which consists of 20 to 49 milliliters of pericardial fluid. We will discuss about three main types of pericardial diseases. First one, acute and relapsing pericarditis. Second, pericardial effusion and cardiac tamponade. And third one, constrictive pericarditis. Today here we are going to talk about acute pericarditis. Pericarditis is inflammation of pericardium. There are four main types of pericarditis: infectious pericarditis, post-MI pericarditis, malignant pericarditis, and uremic pericarditis. Infectious pericarditis can be due to viral, bacterial, tuberculous, or fungal infections. Most common viral infectious pericarditis are Coxsackie B and echovirus pericarditis. HIV also can cause both directly and via immunosuppression, and mumps and herpes also can cause infectious pericarditis. Bacterial pericarditis is rare, but it can be fatal. Staphylococcus aureus frequently in HIV patients causing purulent pericarditis, and streptococcal can cause fulminant and fatal pericarditis. Pneumococcal, meningococcal bacteria, Haemophilus influenza, mycoplasmosis, chlamydia can also cause infectious pericarditis. Tuberculous pericarditis can present as chronic low-grade fever in the evening with dyspnea, malaise, night sweats, and weight loss. This often needs pericardial aspiration for diagnosis, and constrictive pericarditis is a frequent outcome. Tuberculous pericarditis is treated as pulmonary TB with added prednisolone. Fungal pericarditis can be caused by histoplasmosis, coccidioidomycosis, and Candida albicans. This is most common in immunosuppressed or drug addicts or after cardiac surgery. Second cause, post-MI pericarditis. This is more commonly seen after anterior MI and after STEMI. In 20% of patients, in first few days after MI, this is a common presentation. Also can present late in the recovery phase as Dressler syndrome. It is the autoimmune response to cardiac damage occurring 2 to 10 weeks post-infarct. Third one, malignant pericarditis. It can be caused by either primary tumors of the heart, example a mesothelioma, or metastatic pericarditis. Three most common causes of metastatic pericarditis is carcinoma of bronchus, CA breast, and Hodgkin's lymphoma. Leukemia and malignant melanoma also can cause metastatic pericarditis. A substantial pericardial effusion is very common due to obstruction of the lymphatic drainage from the heart. This effusion is often hemorrhagic. Fourth one is uremic pericarditis. It is due to irritation of pericardium by accumulating toxins. This is seen in 6 to 10% of patients with advanced kidney disease if hemodialysis is delayed. So it is an indication for urgent hemodialysis. If we talk about the clinical features of acute pericarditis can present as sharp central chest pain, which is exacerbated by movement, respiration, and lying down, and can be relieved by sitting forward in a tripod position, and pain can refer to neck or shoulders. Classical clinical sign for pericarditis is pericardial friction rub. This is seen in three phases: atrial systole, ventricular diastole, and can be also heard as biphasic to and fro rub. Best heard with diaphragm at lower left sternal edge at the end of expiration, with patient leaning forwards. Features of pericardial effusion may also be present. Large pericardial effusions can compress adjacent bronchi and lung tissue so that can cause dyspnea. Then what are the investigations to diagnose pericarditis? ECG is diagnostic. Widespread saddle-shaped ST elevation, concave upwards, and reciprocal ST depressions in AVR V1 and PR segment depressions. And also, sinus tachycardia can be seen. Rhythm and conduction abnormalities if myocardium is involved. Cardiac enzymes can be elevated if myocarditis is associated, and chest X-ray can show cardiomegaly with ineffusions. Echocardiogram can confirm pericardial effusion. CT and CMR can show thickened or inflamed pericardium. What is the management of pericarditis? We should treat the cause if it is found, and bed rest with oral NSAIDs. High-dose aspirin, indomethacin or ibuprofen. Aspirin is the drug of choice for patients with recent MI. Colchicine also effective in combination with conventional therapy. Corticosteroids for patients with a known immune cause, as there is an associated risk of increased rate of recurrence. Recurrent or relapse in pericarditis. There is 20% of acute pericarditis can develop into idiopathic relapse in pericarditis. There are two types, incessant and intermittent. Incessant means recurring within 6 weeks during weaning off NSAIDs, and intermittent means recurs after 6 weeks of initial presentation. First line treatment for recurrent or relapse in pericarditis is oral NSAIDs.